And I think that this is a really unique opportunity because the system boasts a lot of potential to go forward and save lives. There we go. So it's not only in Facebook, but also I think in research. For about 7 to 10 years or so, we've been able to predict people's subjective well-being, their moods, and more recently, signals and signs of mental illness in social media data. And now we're finally seeing adoption into industry practices and apps, the promises of research that were made, say, 5 or 6 years ago in places like Facebook, and in therapy apps, or in chatbots designed to help with CBT-based therapies. Now, machine learning is increasingly being adopted to work in these areas and others about our lives as they intersect with social media data. Things like hate speech and abusive content detection, engagement with robots and other automated systems. Unfortunately, though, these systems are starting to run into challenging outcomes caused often in part by bad prediction systems, right? We're running into things like racist behaviors or other kinds of engagement that we find unsavory and undesirable in these systems. And I think that this captures kind of some of the risks that we've been thinking about as computer scientists, right? What are some of the risks of bad predictions? Now, popular press has talked about things like bad models that do bad jobs at predicting on language, or GPT-3 making errors, or other kinds of problematic outputs. But in addition to bad outcomes and bad predictions, there's also risk of things when dealing with mental illness, like dangerous or harmful interventions based off of the outcomes of these predictions. In Facebook's case, they now have an opportunity to take an action that might impact other people. Same thing with incorrect or improbable causal assumptions and diagnoses based off of these systems if adopted into clinical practice. Now, these are, like I mentioned before, are starting to emerge in popular press, and people are talking a lot about these problems, right? They're talking about OpenAI and GPT reproducing sexist and racist word systems and gender roles. But this is more insidious than just GPT having some kind of toy problems with its work, right? People are being impacted by the influence of algorithms developed by our systems, us being computer scientists, in healthcare algorithms. And a study in Nature recently revealed that there was rampant racism in decision-making based on cost-saving measures that disproportionately affected Black patients in a hospital system. Now, these are obviously things that we want to avoid as computer scientists, and it's really important that our systems account for these kinds of problems with bad predictions, right? We need better data and better models and better architectures that help solve these problems. But I want to pause and pose a thought experiment, because there might be a world in which we actually solve these problems. Are there consequences, costs, and risks of good predictions? If we black box these problems and say we're able to make predictions with 100% accuracy, there are still some costs, right? Some of these costs can be handing over all of your Facebook or social media or electronic health record data to an AI system that can assess maybe months ahead of time that you may be suffering from depression. And that the power of these AI systems can be transformative, but at what privacy costs? But even in situations where maybe the outcomes of the systems are beneficial, say in diagnosing depression or in other systems, other actors like China and other state actors, police actors, have been using AI-based facial recognition systems to track and abuse ethnic minorities, and to use this to enhance predictive policing, right? Even when these systems work well, there are still risks and costs with these systems. And I think that some of these are really important for us to address as computer scientists, especially working in the domain of mental health. We need approaches in AI and machine learning that are more thoughtful, socially aware, and responsible to deal with things like malicious or nebulous actors, inappropriate applications of AI technology, discrimination and injustice that can happen even with perfect systems. And we need to be attuned not only to the domain of research, whether that be racial discrimination within facial recognition or mental health prediction in social media, but also to the social and contextual complexity of people and community needs. The way that I capture this in my research is with this idea of human-centered machine learning. My goal is to try and make prediction systems technically better, but also working towards better social applications of these systems. Now, you may have heard of HCML, what I'm going to probably call through this talk is human-centered machine learning, as human-centered AI, or machine learning and data science for social good, for social impact. But the gist of all of these fields, I believe, is that machine learning is being used in service of pro-social goals to solve and enhance and augment human capabilities. Now, this is more than just humans in the loop or doing human annotations, but a fundamental shift in the way we think about this work. And in this talk, I'm going to walk you through how I believe that this shift is happening and how we can incorporate more human-centered approaches in the research process for machine learning. To me, human-centered machine learning is a commitment not only to the technical innovations and research output of what I do, but also to the people that I serve with the algorithms that I build. That to me is just as important as that technical impact. And in this way, my work sits between human-computer interaction motivations and applied machine learning and computational linguistics, focused on online communities themselves. To me, I also believe that machine learning benefits from deep understandings of these communities to make more rigorous and ethical systems. Now, the way that I study this and my application area of interest is high-risk health behaviors in online communities. To me, these are a really fascinating case study, not only of the interactions between mental health and social media and connecting to like-minded others about high-risk behaviors, but also in using digital trace data to predict physically embodied behaviors and illnesses. These behaviors include things like suicidal ideation and self-harm, opioid use disorder, and pro-eating disorder behaviors. Now, I'm using the term high risk here to point out that talking about these behaviors may not necessarily be dangerous, but these behaviors are oftentimes connected to the physical world where somebody is talking about harming themselves or engaging in disordered eating behaviors. And these behaviors are very dangerous to the well-being of people who may talk about these, and in some cases may have contagion-like impacts to those who read and engage with these online communities. Now, I want to be clear that I don't believe that human-centered machine learning is just one way to study medical terminology or online communities. And I think that a lot of this work can apply to not only the technicals or not only the social side like I focus on, but also some of the technical approaches. In today's talk, I'm going to be talking to you more about the human-centered side. I have a previous work that I'm going to talk a little bit about some of the technical work to help us sort of ground what I mean by a larger human-centered approach. So a lot of my previous work involves improving computational language models with expert annotation systems built by clinicians and medical practitioners, and using those higher quality labels for precise insights on human behavior. In one study, we were able to quantify levels of mental illness severity in social media data as expressed by people's posts on Instagram. We quantified this into a system of low, medium, and high mental illness severity, grounded with our clinical partners who helped us understand and operationalize this from the DSM. We were able to augment the probabilities of topic models generated by latent Dirichlet allocation with human labels to build automated annotation systems that assess the severity of these symptoms within Instagram posts. We can then apply this annotation system across 26 million posts and have a scalable way of measuring mental illness severity. In a similar system, we've used human annotations to augment Levenstein edit distance measures that detect variant hashtags generated in reaction to platform banning strategies. So Instagram in 2014 started banning hashtags related to eating disorder content on social media or on their platform, and people responded by changing the original tag of thigh gap spelled with I and A to thigh gaps with Ys or multiple Ps. And you can see in this variant and tag chain reaction that the community avoided basically string matching protocols Instagram put on to ban their posts and ban their hashtags from being used on the platform. Now, using this modified Levenstein edit distance, we found these non-standard lexical variations within the community. And we were also able to use this to extract about 8 million posts that use these modifications. And we found that the Instagram banning strategy didn't work. Now, this is a really quick overview of some of the technical work that I've worked on in the past, especially focused on the disordered eating community in Instagram and also Tumblr and some on Reddit. And I wanted to give you this taste before I jumped into the big point of the talk so that you understood the idea of the technical side of this work, involving humans, pulling in stakeholders, augmenting unsupervised models and language models to be able to assess mental illness within social media. Once we can do that, I'm curious about the implications of these systems. And so today I'm going to talk to you about using this kind of approach in service of bigger social goals, not just the focus on predicting mental illness severity or these tag changes, but these bigger implications to bigger problems and values than just the technical side. And for me, a human-centered approach is a bigger approach in computer science than just on health. It can help us discover new information and new prediction strategies. It might also be able to help us understand and innovate in new architectures or approaches to solving problems that before were very difficult without the involvement of human experts. But I also think it emphasizes a cooperative process between communities, important stakeholders like doctors, social networks, and researchers to building systems that really serve people's needs. So what I'm going to talk to you about now is how I've been using recently human-centered machine learning to discover data in social media text. And then I'm going to talk to you about the problem of labels and how difficult it is to generate labels that are reliable and accurate to the mental health signals that we care about. And then I'll talk to you about, I think, sort of the bigger vision for human-centered machine learning as a field. All right, so to talk first about using human-centered machine learning as a tool for discovery, I'm going to talk to you about some previous and current work about opioid use disorder and alternative therapies that people find within social media data. So a little bit of context for opioid use disorder. In the US, the number of deaths from overdose is higher than the number of deaths in car accidents. In 2017 or 2018, 47,000 people died from overdose deaths in the US, and over 450,000 people died from overdose related to opioids like prescription painkillers and illicit drugs like heroin in the world. Now, opioid use disorder is what you would commonly call opioid addiction, and it's something that's really pervasive to a lot of communities. It disproportionately impacts certain communities within the US, including rural and small communities, and those that don't have access to easy medical treatment. Sometimes treatment centers are an hour to an hour and a half away. Now, typically, clinicians recommend several steps to recover from opioid addiction, including the use of methadone or Suboxone maintenance therapies, detox programs, or 12-step programs, things like Narcotics Anonymous, which you might have heard of. And these are all well grounded in the clinical literature. However, as I mentioned, a lot of these communities and individuals are separated from medical treatment. And quite frankly, going into recovery or inpatient detox is very expensive. It can cost $45,000 without good insurance coverage, and insurance is not required to cover addiction recovery treatment plans or inpatient options. So some people go online to try and find ways to recover from their opioid addiction. This is an example of Reddit, which is an online community, or Reddit r/Kratom, an online community of a substance that people have started adopting to help facilitate their recovery from opioid use disorder. In case the text is too small, this person is saying with lots of upvotes, the idea of making kratom unavailable to people who are using it to stay off of other dangerous substances is dark. Kratom is the answer for me. And the top response to this is absolutely. If it's banned, users will still get it and lives will be ruined. For individuals who are using the r/Kratom forum, they're actually using kratom as a way to recover from their opioid addiction, using clinically unverified and off-label use of this medication. Now, it's not just kratom, this sort of obscure substance from Southeast Asia that's been used for centuries as a mild stimulant and relaxant. People are also using prescription medications, over-the-counter drugs, as well as substances like kratom to support their recovery efforts, instead of seeking out traditional treatment therapies like going cold turkey or abstinence or 12-step programs. And part of the challenge with these substances is that they're very elusive to clinicians and medical researchers. Despite there being some self-reported benefits of these substances, there is very limited clinical research on the effectiveness and the pharmacological properties of some of these substances, kratom being sort of the emblematic one, where we don't know a whole lot outside of case studies and some ER reports of people who have overdosed on the substance. People are going to online communities to seek out these substances, and so we got curious and said, what are these alternative therapies that people are using? These clinical alternatives that are not medically supervised and unverified that people are using to recover from their opioid use disorder. Now, I want to be clear. Just because something's clinically unverified doesn't mean it's going to be dangerous. Many substances start as in test protocols as unverified substances that are not allowed to be prescribed. And many of these people are trying to use these substances to get off of what would be much more dangerous things like heroin or fentanyl. If you know anything about fentanyl, a lot of it has been infecting the drug market, where it's being placed into things like heroin to cut it or to increase its strength. And if you're not careful with it, it's very easy to overdose over it. And so in many ways, people are using this as a harm reduction measure. But right now, we just don't know how they're using it and whether or not these substances may be effective. In this way, this serves as a blind spot for stakeholders who treat opioid use disorder. Clinicians don't know about these substances, doctors may be unsure about pharmacological effects or interactions, and caseworkers may have to manage new and emerging addictions. So for us, we adopted a human-centered approach to discovering these alternative therapies to attempt recovery from opioid use disorder, to supplement this discovery process for clinicians and relevant stakeholders in this research. And so when I say a human-centered machine learning process, what I'm overviewing here is sort of a pipeline of how our data is processed. But at each one of these steps, we have deep involvement from stakeholders within these communities, not only from the clinicians themselves, but also from users as well. So what we were able to do is find discussions on Reddit about recovery guided by a clinical expert who could identify these kinds of behaviors, identify 93,000 posts using transfer learning to find posts that are similar to other kinds of recovery. And then using that 93,000 post data set, we can identify the alternative treatments. So let me walk you through how we designed the transfer learning approach with the clinical collaborator. My clinical collaborator is named George. He is a registered psychologist and researcher out of New York City and does work on schizophrenia and opioid use disorder. He helped us design a transfer learning system that we could use to extract signals of recovery from known recovery subreddits related to opioid use disorder, from broader, bigger communities, like say r/trees, which is one of the biggest cannabis advocacy subreddits on Reddit. People use cannabis sometimes to recover from opioid use because it does alleviate pain. And so you can imagine finding lots of subreddits, but not knowing which people are using the drugs for recovery or for abuse. So we built a transfer learning classifier to do this for us automatically. What we found is that a binary logistic regression with a pretty straightforward set of features, the top 10,000 words via TF-IDF, after removing stop words and some data cleaning, actually worked really well at being able to extract recovery signal from the social media data of people and their general use drug behaviors. And one of the things I really like about this model is that in comparison to more complex models that we developed, like we actually tried a couple deep approaches on this, the simple and most interpretable solution worked the best. And my clinical collaborator was really excited about this because it meant he was able to go through the features and help us intuit what we were seeing in the data set and make adjustments to our performance. And what we found is that the performance of this on the 20% held out data set was very strong with an F1 of 0.92, but that in comparison to hand labeled data from George, the F1 in the performance of this algorithm was also very strong at a 0.8. And as a proof of concept system, I'm really pleased with the outcomes of this kind of work. And as I mentioned, he helped us design the training data sets and make modifications to the model, even without himself being an expert in machine learning. So we get this model, we run it on a big data set of general drug use discussion. And so we're able to cut down our data set from about 1.5 million posts down to 93,000. The next thing that we want to do is be able to extract those alternative therapies or things that we are curious that people are using, but we have limited clinical insights on those behaviors. So we came up with another extraction system to get alternative therapies that involve the clinical as well as the user's own descriptions of their behaviors. We took those 93,000 posts and built a word embedding in Word2Vec off of the text of the post of people who are recovering from their opioid use disorders. Then we search for substances that we know to be related and involved in recovery, like Imodium, or other substances that are often prescribed like methadone. Now, this is an important step because it requires George's insights about how he treats addiction and the variety of substances between over-the-counter medications, prescription, and other things that he would recommend to his patients. And we wouldn't be able to do step 2 without knowing having his insights. Then leveraging the way that word embeddings work and projecting similar use words into a high representational space, we can use high cosine similarity words to the known substances because they will be used in similar ways in descriptions of how people recover. So we can look at words that are used similarly to methadone or other over-the-counter prescriptions that George has identified, and then find those with high cosine similarity and investigate how people are describing those substances. We randomly select 10 posts for the words that we find that occur closely, and I believe our cosine similarity threshold for this was 0.07 or 0.7 or 0.75, so very similar usage in the data set. And we select 10 posts and go and look at how people are describing how these substances affect them. And we go through and validate and identify a list of substances that people say that they're using as an alternative therapy. And what I think is really cool about this approach is that rather than sort of using the word embedding itself to automatically generate those substances, we use the user's own self-descriptions of how the substances matter to them to narrow our list down to make something more grounded in their own experiences. Here's a list of the 20 substances we found, and this was published in 2019 at CHI. Now, what I think is cool is that most of these substances have been reported at best in case studies and small-scale reports. Things like kratom and iboga are unknown substances to many people outside of the opioid use disorder communities. But you may be scanning this list and seeing some things that are familiar to you, things like Xanax and Valium, antidepressant and anti-anxiety medications. There's also some anti-seizure medications, as well as some over-the-counter drugs like niacin and loperamide. And I think that this is a really, really awesome approach because we were able to leverage those users' experiences to narrow this list down and then find their own disclosures of this being important to them themselves. I'm going to give you an example of one of those users' disclosures. So this is an example of the use of loperamide, or also known as LOPE or Imodium. You might have heard or used Imodium yourself. It's an anti-diarrheal drug that's commonly given to stop one of the more uncomfortable symptoms of opioid recovery, which is the relief of chronic constipation. Now, what we found is that people in these communities are actually reporting using Imodium as an alternative therapy. In fact, these communities, people came up with the slang term LOPE, or L-O-P-E, short for loperamide, to refer to this drug that they would take at very high clinical doses. Now, George told us that we might want to look for loperamide or Imodium in our data set because he often prescribes it to his patients to help them get over that first week of the relief of chronic constipation. But we were shocked when we saw that people were talking about using loperamide of 60, 70 doses of loperamide every 12 or 24 hours. And it turns out if you go through the casework and some old research from the 70s, loperamide or Imodium at high enough doses is actually an opioid. And people are claiming that they're now getting hooked on Imodium instead of heroin or instead of another substance, but that they're using this at such high dosages that clinical collaborators can't predict how this is going to interact with their central nervous system or influence other treatments that they may be put on. And this was really, really worrisome to my clinical collaborator, right? He's looking at this and saying people are blending up 70 Imodium pills into a smoothie and they're taking it once every 12 hours. That's wild. We have to know how much they're dosing. And so what we're working on right now is a dosage detection system that can automatically extract these dosages amount, these 60 pills, half a teaspoon, all of these things from social media data. Now, this is a particularly difficult problem. If you've heard of like concept extraction from electronic health records, you know that these clinical language extraction systems exist and work really well in EHRs. But social media data compared to EHRs is quite messy. People are using slang terms, they're misspelling things, and new alternative therapies are being tested and tried organically in the social media text. And so it's much more difficult to apply systems built off of EHR or more formalized language weren't cutting it, or they don't cut it. And I can verify with you that they didn't cut it. So we've been working on using deep learning approaches to automatically extract known and new alternative therapies and their dosages. So my clinical collaborators can actually start investigating their effectiveness. So far, we have about 1,000 expert annotated posts across 4 entity categories. Now, these entity categories are related to dosing strategies across days, weeks, and the milligrams or the dosage amount that a specific person is taking at a time, in addition to the drug amount. And what we've done is we've built a system or a pipeline that uses word embeddings via Word2Vec that we built before. And we put a named entity recognition system and a relationship extraction system on top of this approach to be able to automatically pull out these dosage and drug-based pairs. What we found is that with a loosely connected convolutional neural network, we've been able to get an average F1 score of 0.86 across those 4 entity categories. Now, I mentioned that we had 1,000 expert annotated posts, but most people talk about a lot of references to these drugs and dosages themselves in these categories. And so we have over 5,000 entities annotated across this data set. My research assistant, Aldo, has recently been working on implementing a bidirectional LSTM, as well as testing burnout in this. And initially, we're seeing a 3 to 4% increase in accuracy at the cost a little bit of speed and performance, right? Bigger models are going to need bigger data. And so we're trying to balance the trade-offs of the time spent annotating this with George and myself and the impact of the model and its quality. Now, one of the things I've been thinking about, and I think you might have noticed, is that all these slang terms are popping up. And there's these words that are being used in multiplicative and multi-sense ways. So it's a classic framing for word sense disambiguation tasks within natural language processing of how people are using terms like lope to refer to a substance or to refer to things that may not necessarily map to the sense we expect them for. And we've also noticed too that people are using substances and the names of substances in different ways, depending on where they're at in their recovery journey. People who are further along in recovery will often refer to their drug of choice as heroin or my drug, not actually referring it to by its street names or slang names like H or dope, because they want to disassociate themselves with the person that they were. And so we're wondering if word sense disambiguation here may actually help us in 2 ways. I think it may actually help us disambiguate the uses of these substances for some of the false positives and false negatives we get in the classification system of whether or not someone's recovering or not. But also we may be able to make the system more robust to these shifts in people's approaches, and using word sense disambiguation as a way to detect as someone moves through their recovery journeys. And so this is something my Aldo discovered last week, and we were both really excited about incorporating this possibly as a layer to this architecture or as an entire project about people's use of terms as they move through their recovery journeys and how you can detect this using natural language processing techniques. All right, I'm gonna pause here for 15 seconds. If there are any questions so far, feel free. I think we're doing pop off of mute or questions going through chat.
Either one, yeah.
All right, if there's no clarifying questions, I'm going to keep going. If I see you pop in chat or you want to unmute to ask something for clarification, please go ahead and do that. All right, so I've talked a lot about my work on using human-centered machine learning approaches, this collaborative approach with qualitative analysis and sort of reflecting on the data and the needs and comments from people in those communities as a way to discover new information for medical practitioners. I want to move on to another core problem that comes up in all machine learning, including my own, which is getting and labeling training data. This is often for many people the most time-consuming part of a project, and it's crucial for reliable, replicable, and accurate modeling, no matter what the domain is, whether it be image object recognition or detecting mental illness and social media data. Now, I think we all, if we've built a machine learning model, you know that this process is time consuming. It also can be expensive and can be very draining on the research team, since not a lot of progress happens while you're having to label data. We run into this ourselves and having to label hundreds of posts for this named entity recognition system that I mentioned to you before. Instead of just relying on expert labels, researchers within the mental illness and prediction space have come up with what we call proxy signals, or ways that they can annotate data that may not require that expert annotation. It speeds up the annotation process. So researchers, computer scientists have spent a lot of time coming up with these proxy labels. This includes annotations by computer scientists or their graduate students. This also includes labels generated by community and network affiliations using hashtags or being part of a community like r/kratom or r/methadone. Also using things like self-disclosures, keyword matching to hashtag depression, acquired annotations or news reports, all of these new ways to try and scale up data to be able to know if somebody might be suffering from the mental health or mental illness disorder or symptomatology of interest. And this has been used across a wide variety of mental illnesses, not just eating disorders and opioid addiction, but also in suicide, stress detection, and other disorders in the same category. And so we started wondering, after we got through the opioid addiction project, of, okay, are these strategies that we're using to generate labels, guilty as charged, I've also used some of these strategies myself, actually valid representations of mental illness? So can you rely on r/depression, a major community for people who are seeking support about depression? Are all of those people depressed? Or even if they're not, can you use that as a valid source of what the experience of depression looks like? Now, people in machine learning oftentimes will claim that because their algorithms get outstanding performance, that the labels and the models that we build are valid representations of computational or of depression, right? And then we can say maybe some of those features are valuable for depression detection, sort of getting at I want to say the hint of a causal approach to these problems. But when we use terms like validity to refer to our models actually measuring the thing that we care about, I think we're actually getting two terms confused within the domain of computer science and the domain of mental illness, where validity in computer science means that our model is robust and actually performs well. And in some cases in cases for mental illness, validity refers to a very specific construct or the mapping of these theoretical constructs to the real world and validating those through extensive annotation systems. And so I love Vizzini, or I love The Princess Bride. It's like, you keep using that word validity, but I don't think it means what you actually think it means. And I think part of the challenge here is that we've got an interdisciplinary research area using two terms that have colliding meanings with each other. But it's really important that we be careful about what we mean when we say our work is valid, because valid means rigorous, it means reliable, and it means replicable. And high performance doesn't matter so much if you're not actually measuring the thing that you think, or the thing that you think you're measuring in social media data. So what we did is we started exploring the literature of measurement and exploring the idea of construct validity, which Shadish, Cook, and Campbell, in their seminal book about measurement and experimental studies, define construct validity as making inferences from the sampling particulars of a study to the higher order constructs that they represent. It's crucial that our constructs or proxy signals to identify mental illness and social media data map to known standards of illness, and that these proxy signals are accurate representations of those clinical standards. In short, we are curious if the operationalized ideas match the concepts that the researchers claim to match. And so we took the lens of measurement studies from the social science to evaluate how training data was being produced for these works. To do this, we did a systematic literature review of 75 papers that predict mental illness from social media data, in work that's very similar to my own. We then examined the methods in the study design that contribute to construct validity and evaluated study design practices to make sure that this work actually claims and measures what it claims to measure. And I'm going to walk you through an example, I think, that really shows where the gaps are in some of this work. One of the most confusing terms from our data set were papers that studied anxiety. Out of 75 papers, 6 to 8 papers mentioned anxiety in some fashion. But the problem was that it wasn't clear how they were defining what anxiety meant. Anxiety itself, as I mentioned earlier, kind of tied to the word sense disambiguation task I mentioned, has a lot of senses or definitions of what it means, right? Anxiety can be symptomatology that influences other disorders. It's a transient emotion that people experience and that I'm experiencing now because I'm a little anxious giving this talk, right? There's also lay usage referring to emotional states or traits of a person, someone's just like an anxious person. But it can also refer to a category of nervous disorders, including social anxiety, panic disorders, and generalized anxiety disorders, which would be just diagnosed and prescribed, or like diagnosed and treated by a clinician. Therefore, strong publications should disambiguate which one of these that they're measuring in their data set to make sure that they're clear about what their results can promise, especially as it's related to downstream clinical and intervention efforts. But the fact of the matter is, nobody defines what they actually mean when they say that they're measuring anxiety on social media data. And saying and using terms like I'm anxious or hashtag anxiety don't mean that you actually have an anxiety disorder, nor which of the many anxiety disorders, even if you do have one, that you actually have, which makes the prediction system used in this case wobbly at best. And in the literature review, we identified fundamental disconnects between the clinical grounding and the applications of these terms. Now, I want to be clear. My work is included in this data set, and there are some more solid and less solid approaches within this work. But what we found was that this was true across most of the studies, no matter what clinical construct they were trying to operationalize, how general or how specific it was. What actually predicted the success of the construct that they were developing tended to be the researchers' reliance and collaboration with domain experts who helped them triangulate ideas of what it meant to be stressed out or suicidal or anxious in this case. Now, I think that there's a problem with this, in that if we make abstractions and representations in ways that are loose or not tied to the clinical construct, we don't actually solve the problems that we claim to solve. And this makes our work, very difficult to reproduce because we don't have a grounded construct that we can compare other people to. And quite frankly, data sets in this space aren't often released because of the sensitivity of predicting mental illness on people in public data sets. That makes it very hard to verify that what we actually do is what we say we do. And it sets up downstream problems and adoption of this into clinical practice. Imagine me showing that anxiety example to clinicians who want to use this as a triage or screening tool in college mental health services, right? There's no way they're going to buy into a screening tool that can't tell the difference between somebody having a transient emotion because they're anxious about a test versus a longer clinical term or longer clinical manifestation of anxiety that they need to actually take action about in very different ways. So some of our current work is actually trying to return to this focus on measurement from the social sciences, to adopt protocols and mapping the development of these annotations to known factors within measurement. How can we, basically we're trying to figure out how we can formalize and articulate a process to evaluate if proxy signals actually measure what they are measuring. And if they don't, how can they be better aligned to the clinical side? So this work is actually in collaboration with the Centers for Disease Control and Prevention in the US, or the CDC, in trying to understand how we can formalize this process, which not only helps us in making better machine learning models, but for them makes public health surveillance of changing trends in mental illness much more precise, so they can rely on new sources of data like Twitter or Reddit or other forms of digital trace data to accurately assess changes in population scale mental health. So we draw on the sciences from the measurement of social sciences. Now, these ideas may be familiar to you if you've ever done a corpus annotation task in linguistics, studied a little bit about psychometric evaluation or scale development for detecting depression or anxiety. So bear with me if these kind of seem repetitive. I think it's important that we have this formalized process in computer science so that we can build labels for concepts that we really need to get right. The way that we did this is by operationalizing and studying risk and protective factors of suicide. Now, predicting and prevention of suicide is one of the most challenging public health problems and is at one of the highest levels of priority for the CDC. Most computational work in this space focuses on binarized or categorical indicators of risks, what I like to call the stoplight system of red, yellow, green, or high, medium, low. And to be clear, I'm not trying to pick on anybody here, right? Some of my work that I mentioned earlier in this talk is guilty of the low, medium, high bucketing. And I believe that we're at a really opportune place working with someone like the CDC to be able to improve those annotation systems. Now, the problem with bucketing indicators of risk is that if you know somebody's at risk for harming themselves or injuring other people, you need to know how you can intervene. Without knowing the nuances of that intervention or what's bothering them, it's really difficult to make an assessment of whether or not they should be pointed to, say, internal resources or to supportive friends on a platform, or whether more elevated interventions like police or social worker interventions matter. And in selecting between those, you need to know the nuances. So what we did is we took the clinical literature and its focus on risk and protective factors of suicide, This is drawn from a socio-ecological model of suicide development, which considers individual factors as well as life and community things that might influence somebody to be at more or at less risk of injuring themselves. This includes risk factors, which I think we traditionally think about when evaluating risk, like crisis, financial problems, mental illnesses getting worse or being untreated. But this framework also operationalizes and includes nuance in it by studying protective factors, positive social support, and the desire to get and feel better, access to clinical resources and treatment, which we have extensive research that shows that having access to these things decreases the risk for suicide. So what we did in the study was formalize a framework to evaluate construct validity in developing scales to understand risk and protective factors within the social media data set. And at the same time as we were building this framework, we used Reddit data to be able to understand people who were coming in for suicide crisis to a special suicide crisis forum to understand how they were communicating their risk and protective factors. So not only is this based on the research that shows and grounds these factors, it's also focused on the unique expressions of people within these communities. So here's the scheme that mirrors an annotation scheme from computational linguistics and psychometric scale development. Now, I mentioned earlier, if you know anything about annotation in the rigorous sense, this will feel familiar to you. There's processes of looking to the prior work, asking stakeholders what they value, piloting the study in the substantive validity phase, right? Moving on to an iterative process of item selection and refinement and testing. And then at the end of this internal validity phase, evaluating inter-rater reliability. These all feel like familiar pieces of building up annotation systems that computer scientists adopt. But our goal was to formalize this process so that others could use this to rigorously and replicably develop annotation systems that others can then do the same thing. And we can build better data sets that are more reflective of the processes that we want to measure from this. What I can tell you is that our initial system built using this approach is showing really high inter-rater agreement between a mixed team of computer scientists and public health experts in suicide and mental illness from the CDC. And because it was developed with this context in mind, more richly encompasses the space of suicidal ideation. And initial machine learning models built off these labels perform much better at identifying risk and protective factors than those that were built off of binarized or categorized elements of risk in the first place. Now, I want to talk to you a little bit about what I'm thinking we're going to take this work, right? Because this work is still in progress. And I'm really excited about the opportunities it has, not only for mental illness, but also formalizing processes within the larger applied machine learning community of developing rigorous and excellent training data sets. I'm really excited to be able to validate our approach with more external validity. So in addition to validating on Reddit, does it apply to other suicide crisis communities, perhaps more niche ones that are supportive of people with different identities or risk factors that would uniquely need to be accounted for in an algorithm that helps identify when to make an intervention? But I'm also really curious about using this to evaluate the proxy signals themselves for reliability and accuracy, and comparing these systems to the systems built off of proxy labels that are unverified to stronger and more formally validated proxy approaches themselves. And then ideally, in the future, coming up with ways that can scale clinical annotations that avoids the traps of clinical annotators in the first place, which is that they're expensive and it's time consuming and difficult to develop large enough data sets that you can use deep approaches on. And that would open up a whole new area of research because of the size and the validity of the data set. All right, so I've talked to you a lot about using human-centered machine learning for discovery, as well as using it for an approach to think about a problem that's endemic to machine learning. I want to wrap up by talking about where I see this going next. And one of the biggest catches that I find in talking about human-centered machine learning to other folks. So I've talked a lot about methods, right? And about tools and techniques that can be used to help make algorithms better. This includes extensive collaboration with domain experts, interpretable models, human in the loop or machine in the loop approaches, what I think can be seen as like a bunch of robust and useful techniques and methods to improve ongoing systems. And in many ways, human-centered machine learning can be seen as a toolkit of approaches, or a set of lenses that have been built into already existing projects already. And while I want to say, yes, you absolutely can adopt new approaches that build and integrate human insight and understanding into machine learning models to make them better and more aware of the context in which they perform, I want to push us for a second to think of human-centered approaches as more than just a toolkit of methods, because it's tempting to say, I've used this one approach, therefore my work is human-centered and adequately covers stakeholder needs and clinician input and actually gets the problem. I took this image from the Human AI Institute at Stanford because I thought it was emblematic of the question that comes up with human-centered machine learning. Oftentimes we envision people playing in labs with robots or interacting with systems like Microsoft's Tay or chatbots, right? We think of a person, that physical embodied person playing with physical real things. But I want to pause here and reflect that in my systems, nobody physically interacts with my algorithms other than me and the research team. My users in my data sets are having algorithms applied to their work. And in reflecting on what a human-centered approach looks like to machine learning, it's just as important to think of the machine learning as it is to think of who that human is, right? They're not physically embodied, and so we don't have the same kind of emotional reactions that we would to somebody or 100,000 people that we've scraped off of a data set. And for me, that leads me to start thinking about how I can better accommodate these people within my data sets and a focus on values for human-centered machine learning. The whole thesis of the way that I think about problems is we should be prioritizing goals and values that center who that human is within our technical research. Things like making machine learning more interactive or personalized, thinking about questions around equity, fairness, and justness, as important as the technical impact of our work. And in many ways, I think of myself as a steward, of somebody who's responsible and puts the needs and the goals of the stakeholders at the front of what I'm doing. We don't compromise our scientific integrity or lose rigor when we start adding these values into our work of empathy and personalization and justness and fairness. And I actually think that making these values explicit in our research approaches makes us more likely to get it right from the first time, right? We listen to stakeholders and what they need for mental illness prediction or hate speech detection or whatever application system you can envision. And for me, a values-driven approach is a steward-based model. And I think this answers a lot of questions that have been coming up with the NeurIPS negative implications section that's been requested in new papers, and in the increasing focus on ethics and impact of social systems and how they impact other people. To me, I hope through this talk that you've seen how this ethos plays out in my research, and that by adopting values, we don't make compromises on our scientific integrity. At the end of the day, I'm optimistic about our roles in making technology more rigorous and ethical. And to me, machine learning is the way that we can do that in large-scale data sets. But without a human-centered approach, we run the risk of losing focus on the things that brought us to this place in the first place, like people, communities, diagnosing and assisting others. We're responsible to the communities and individuals we help. And for me, I think a human-centered approach helps with these kinds of ideas and makes us, at the end of the day, a better discipline for the rest of the world. Thank you to all my co-authors and collaborators, my lab of students at Northwestern. I have a gaggle of undergrads and they're wonderful, as well as the organizations who have financially supported and provided research and data support for my work going forward. Thank you so much, and I'd be happy to take any questions you have. Thank you for listening.
I'll kick things off with a question. So it seems like mostly what you talked about today was sort of the perception side of the problem. How do we know what alternative drugs people are taking? What can you talk about your thoughts on what the kind of intervention side looks like?
Yeah, so that's something I get a lot of questions about and that I personally have vested research interest in. I didn't talk about it today because I don't have a lot of progress in it. It's a new area for me. One of the things I think is really important when doing an intervention is destigmatizing what it means to intervene. So a lot of times people think of like Hollywood style interventions where there's a dark room and the dining room table is lit with a bright light and someone's sitting there threatening to take you away from your life if you don't go to inpatient, right? It's these really scary and really kind of harmful views of how an intervention should work from the clinical perspective, but also from the social perspective, in that we're stigmatizing these people and telling them that they're bad people that need to be removed, right? I want to step back and say, like, okay, how could you make an intervention that meets someone where they're at? Whether that be possibly putting somebody inpatient because they need to be inpatient versus making more nudges or suggestions to someone. In some interview studies I did with a master's student at Georgia Tech, we found that people who participated in disordered eating communities didn't mind interventions. They just wanted them to help them reflect on their current emotional state, like having a mood tracker or a little text box that they can indicate what they were doing before they got to the place where they felt triggered to overeat or to binge or purge, right? We can think of more novel intervention approaches, I think, than just that catastrophic intervention of banning somebody from the platform, deleting their content, preventing them from using support resources that are important. That is my initial thought, and I'm working on ways to try and instantiate that to understand what people need. But that's pretty difficult because you need to know where someone's at to be able to give them a good nudge.
Hi, Stevie. If I have a chance to ask a question here, first of all, great talk. Really enjoyed it.
Thank you.
So I wanted to ask, are you facing any challenges, maybe on the transfer learning side, and like looking at how some of the NLP you're doing in some social media platforms may not translate well to other ones? So for example, Reddit has a really high degree of people being anonymous. And so the way people might talk about their situation when they have this anonymity might be different than how people might talk about it if they lose it. Like say you bring it over to Facebook. So how have these differences in language from platform to platform, how might that crop up in your work, and how is that potentially addressed?
Yeah, so that's actually a great question. One of the things that we found so far is that using pre-trained models to build these transfer learning systems actually causes us to have worse performance, because pre-trained models off of like Wikipedia or Google News or other data sets don't have the specificity and the nuance of the communication that people are using. And that's in a specific case of using pre-trained models on Reddit data in particular. Now, I can tell you that the pre-trained models our transfer approaches work better in moving between Reddit to, say, Tumblr. But part of that is the expressiveness of the platform. So Tumblr and Reddit give you large amounts of text space for you to articulate yourself. They work less well moving to something like Twitter, where you're bound by, 280 characters at this point? And so I think that there may be opportunities to build base models about understanding mental illness disclosures as a unique data set that you can then pull on a modified approach from the target domain, like pulling in embeddings and retraining models off of Twitter data when you're trying to pull something that was built off of Reddit. The short answer is it's just really hard. And I've spent a lot of engineering on trying to solve those problems. Most of it involves getting more labels and nuancing models to have features that are more reflective of the target. I think that there's going to be limitations, unfortunately, in applying something from like the depression side, a trained model there, to the anxiety side. There's not going to be that ability to have a fully generalized approach, which adds, additional complexities onto developing systems that can apply to a wide variety of conditions.
Yeah, thanks.
Daniel, I see you're raising your hand. Do you want to ask a question?
Yeah, hi, thank you. Great talk. I really liked it. Yeah, I was just kind of reflecting on this work you're doing with construct validity, and I totally agree. It's very important to have research define what we're using in each study, so we can understand, what the model will predict to. But I was also thinking, if the goal is to kind of match annotations or whatever type of data we're using to clinical constructs, I was just kind of thinking how limited sometimes the clinical constructs are in psychiatry in particular, because a lot of these mental health disorders don't reflect kind of underlying diseases as they do in other fields of medicine, but rather kind of a a conglomerate of signs and symptoms. So, you know, and there's a high comorbidity rate. There's, you know, a lot of these disorders are episodic. So maybe even a clinician's assessment at one point may not be valid, you know, a couple weeks or months later. So yeah, I wanted your thoughts on this. And obviously there's this kind of room for AI to kind of find new categories and new constructs, disease subtypes, and, you know, transdiagnostic kind of constructs.
Yeah, I absolutely agree with you. So I was joking with a collaborator at one point about the difficulty in building an assessment system for depression. And he's like, Stevie, you know that depression diagnosis is 150 years behind all other disease diagnosis, which is totally true. And we're still coming to find that our diagnostic criteria and patterns are causing gender and racial splits, right? I think a lot of the work in autism spectrum disorder in particular has shown that there's huge gender differences in how people are diagnosed with autism, because girls are better at masking social signals because they're taught how to do that. And so I think your question's really important. To me, I actually think that the future of dealing with this is to use machine learning to understand behaviors and changes in behaviors over time, rather than focusing on the identification of illness as a specific construct. Because as you mentioned, people's severity of their depression or anxiety or a disorder that they're going through changes over time and may actually be very different between a 3-month or even a 1-month episode. And to me, if we could track behaviors better and use that as a way to understand how things like posting rates late at night are changing, or people's use of certain language are changing over time, and use that as a way to help inform people when they're looking at social media data to say, what's actually going on here and what can I use this data to make sense of? I think we get closer to that construct. But at some point, we're going to be limited by the diagnostic capability of the construct themselves, especially when the constructs themselves are flexible, is not the right term, but I think describes the difficulty in applying it to the space. Hannah Wallach and Abby Jacobs have a really fantastic paper about this, about fairness and measurement, that describes exactly this problem, but applied to fairness. And so I think that I've really been inspired by some of their work about contested categories and how do you start building that into these systems. The short answer is I'm not sure, but it's definitely something we need to be aware of.
Oh yeah, that's very interesting. Thank you for that reference. Yeah, I think if like one approach is just looking kind of inter-individual changes, longitudinal changes, and just seeing what kind of works and how you can monitor a specific individual changes is kind of a promising field for this.
Oh, I totally agree. It's something I've been really excited about, from like not only in monitoring people's changes over time, but involving people and telling you what those changes mean. So I'm imagining like an active approach to helping people self-label their own disorders or disease. Like, oh, I got off of social media here because I actually went inpatient for 3 months, right? In some of the work of my lab mate at Georgia Tech, she would notice that people just drop off when they were going inpatient. And most of the time we just like delete those periods of inactivity from our data sets and throw them out. But that period of inactivity is actually really important to these patients of, I wasn't available to do anything because I was literally not allowed to use my phone. And thinking of how we can incorporate both that longitudinal approach you brought up, as well as the person's approach to making systems that work better for them, I think is going to be one of the futures of this technology. But we need data and we need good labels and we need reliable systems to do that well. And that's, I think, one of the gaps right now preventing us from getting there.
Yeah, fascinating. Thank you.
So I think we're going to wrap up there because we do have some time constraints on the other side. Well, thank the speaker again for the great talk, and hope to see you all again at another one of these seminars.
Thank you so much.